All right, welcome to lecture 19 of our cardiovascular series. Today we're going to talk about aortic stenosis, a crucial topic for USMLE Step 2 CK. I'm Dr. Duarte and I'm excited to be here with you guys. Let's get started. Aortic stenosis is a progressive narrowing of the aortic valve. It's most common in the elderly due to degenerative calcification. The narrowing obstructs the blood flow of the left ventricle, leading to pressure overload and heart failure, and if left untreated, eventually death. Degenerative aortic stenosis behaves a lot like atherosclerosis. It leads to calcification that stiffens the valve and limits leaflet's mobility. As the valve gets narrower, the left ventricular pressure rises, triggering concentric hypertrophy. This thickened heart muscle becomes less compliant, so the LV ends up relying more heavily on adequate preload. Get this information. This thickened heart muscle becomes less compliant, so the LV ends up relying more heavily on adequate preload. Here's the thing. If there is too much volume in this kind of patients with concentric hypertrophy, patients can decompensate quickly with pulmonary edema, because the blood, flows backwards if there is too much volume. If there is too little, they can go into shock. You have to understand that. Why? Because aortic stenosis patients have a fixed cardiac output. They have fixed cardiac output. They can't really boost their stroke volume, so they are preload dependent. In other words, too much fluid in this kind of patients, pulmonary edema, thanks to diastolic dysfunction. Too little fluid, shock, thanks to being preload dependent. Did you get that? Let's proceed. Remember this pressure curve? In green, we're looking at the pressure inside the left ventricle, and in blue, the pressure inside the aorta. Now, right here, the mitral valve closes, but the aortic valve hasn't opened yet, right? Once it finally opens, the pressure inside the left ventricle keeps rising. But take a look at the pressure in the aorta. It doesn't rise like it should. Ideally, it should follow the LV pressure up to here, but because we are dealing with a stenotic valve, that pressure can't be transmitted effectively into the aorta, so the aortic pressure stays lower than expected. Okay? This curve here is the pressure volume loop inside the left ventricle. So different from the pressure time curve we just talked about, this is pressure volume curve inside the left ventricle. Now, just using pattern recognition, just taking a look, you probably remember this tall loop screams increased afterload. That's what it tells you. Classic aortic stenosis. You probably saw this in, USMLE Step 1 prep, right? Because of this stenosis, the curve is also narrow, which tells us the stroke volume is reduced. We're not ejecting much. That makes sense? And since so little blood leaves the ventricle, the end systolic volume, right here, the end systolic volume is elevated, meaning more blood remains in the left ventricle after systole. So bottom line, tau and thin loop, aortic stenosis. Okay, let's go. Let's look at the main causes of aortic stenosis by age group. In people over 70, the most common cause is degenerative calcification. In younger adults, around 40 to 60 years old, a bicuspid aortic valve is a congenital cause, the main cause. So every time you see a question bringing a patient with aortic stenosis that is younger than 60, think about bicuspid aortic valve, okay? While rheumatic fever disease is more common in the developing world. Finally, congenital aortic stenosis can also occur in infants, but it's rare. On histology, we see signs of chronic inflammation, mainly macrophages and lymphocytes. There's also fibrosis and lipid accumulation, similar to atherosclerosis. So get that. The physiopathology is pretty much the same between aortic stenosis and atherosclerosis. Over time, this leads to calcification, which stiffens the valve and limits its mobility. Symptoms usually appear once aortic stenosis becomes severe. The most common is exertional dyspnea. Patient may also have exertional angina due to increased oxygen demand and decreased blood flow through the coronary arteries, or even syncope or pre-syncope from reduced cerebral perfusion. As the disease progresses, signs of heart failure can develop, like JVD, peripheral edema, and pulmonary congestion. On exam, the hallmark finding is a harsh crescendo-decrescendo systolic murmur, diamond murmur, best heard at the right upper sternal border and radiating to the carotids. Very high yield this information. So that crescendo-decrescendo shape gives it the classic diamond-shaped murmur. You might also hear a soft or delayed A2, along with a narrow or paradoxically split second heart sound. Normally, inspiration delays P2, remember that, due to increased venous return, that's basic, which widens ST split, right? That's the normal, what we expect. But in aortic stenosis, A2, which is the closure of the aortic valve, is already delayed. So you might actually hear the splitting during expiration. And then during inspiration, P2 catches up to A2 that was late. So P2 gets late with inspiration and then catches up A2 and then the split disappears. So this is paradoxically split second heart sound. So it is a split that disappears with inspiration. We call paradoxical splitting a split that disappears with inspiration. Also common is an S4 gallop due to left ventricular hypertrophy. And don't forget, pulsus parvus et tardus, weak and delayed pulses, another classic clue for aortic stenosis, for severe aortic stenosis. Let's proceed. Echocardiography is the key test to confirm aortic stenosis. It typically shows thickened calcified valve leaflets with restricted motion. And severe AS is defined by a jet velocity of 4 meters per second or greater, a mean pressure gradient of 40 millimeters of mercury or greater than that, and a valve area of 1 centimeter square or smaller than that. You might also see left atrial enlargement and left ventricular hypertrophy on the echo. And the more stenotic the valve is, the greater, the pressure gradient between the left ventricle and the aorta. So that's a principle that's nice for you to understand. And the faster the blood has to move through the narrow opening, the more severe is the aortic stenosis. That's why we measure the jet velocity and the mean pressure gradient in between the aorta and the left ventricle. Here is, we're taking a closer look at the aortic valve, and you can clearly see the small valve area characteristic of severe aortic stenosis. On ECG, you often see signs of LVH, pretty much it, especially increased voltage. You don't really need to memorize all the formal criteria for LVH for your step 2 CK, but here's what you look for. Deep S waves, for example, in V1 through V2, STT changes consistent with strain pattern, and signs of left atrial enlargement as well, like the Morris index in V1. These are classic findings that can support your suspicion of aortic stenosis, especially in the context of a patient with systolic murmur and symptoms. When evaluating a systolic murmur, it's important to consider other conditions too. Aortic regurgitation has a diastolic murmur, not systolic, will be the subject of our next lecture here in our cardiovascular series. And it's going to show a wide pulse pressure with bounding pulses. Hypertrophic cardiomyopathy tends to occur in younger patients, and its murmur gets louder with valsalva, which is kind of unique or standing and is best heard at the apex. Supraventricular aortic stenosis presents with a murmur higher up near the first intercostal space and may have a substernal throw. Pulmonic stenosis is heard at the left upper sternal border, increases with inspiration, and is often associated with isolated right-sided heart failure. All right, let's go. Medical therapy for aortic stenosis is limited and mostly used as a bridge to valve replacement. So we just use medical therapy as a bridge to valve replacement. If the patient has symptoms, LV dysfunction or uncontrolled hypertension, we can try to offer temporary relief. That's pretty much it. You can try to use beta blockers. Beta blockers may help with symptoms like angina or exertional intolerance. We can try using diuretics, but we should use it cautiously. okay, cautiously, if there is volume overload. But be very careful. Why? Because these patients are preload dependent. So don't over-diurese a patient with aortic stenosis, severe aortic stenosis, because remember, they are preload dependent, okay? So also be careful with nitrates and ACE inhibitors, especially if the patient is hemodynamically unstable. They can drop preload and make the symptoms worse and make the patient become hypotensive. Management depends on the severity of aortic stenosis. For mild to moderate cases, we just monitor. Usually with, clinical follow-up and repeat echocardiogram every 1 or 2 years. That's it. But for severe symptomatic aortic stenosis, the definitive treatment is aortic valve replacement. This can be done surgically, which we call SAVR, S-A-V-R, or surgical aortic valve replacement, or through a catheter-based approach in the cath lab known as TAVI, transcatheter aortic valve implantation. We move forward with valve replacement if the patient has any symptoms, or if the left ventricular ejection fraction drops below 50. So that's pretty much the indications. Those are pretty much the indications that we need to, replace the valve of the patient. When deciding between SAVR and TAVI, surgical aortic valve replacement versus transcatheter aortic valve implantation, we look at the age, surgical risk, and overall health. For patients between 65 and 80, both are valid options, actually, and the decision should pretty much be, shared between the patient and the care team. TAVI, transcatheter aortic valve implantation, is a less invasive procedure where a new valve is inserted via a catheter, usually through the femoral artery, and deployed inside the diseased aortic valve. It is preferred in patients over 80, in younger patients with less than 10 years of life expectancy, or in those of any age with high or prohibitive surgical risk. That makes sense, right? It's less invasive. Aortic stenosis can lead to several serious complications. Heart failure may develop and become irreversible if left untreated. Atrial fibrillation is common, often due to left atrial dilation. Ventricular arrhythmias can also occur. If preload suddenly drops, like from dehydration, from diuretics, from medications, patient can go into obstructive shock, right? Because they have fixed cardiac output and they are preload dependent. There's also a risk of sudden cardiac death in these patients. And don't forget Haid syndrome. What is Haid syndrome? Which is a GI bleeding from angiodysplasia combined with acquired von Willebrand factor deficiency. That's crazy, right? Once severe aortic stenosis becomes symptomatic, the prognosis is poor without valve replacement. That's it. Average survival is just 1 to 3 years after symptoms in a severe aortic stenosis. So TAVI offers excellent outcomes for elderly or high-risk patients, while surgical aortic valve replacement is more durable and preferred in younger patients with longer life expectancy. We're approaching the end. Let's take a look in this simple case here so you get some concepts. This is 82-year-old man with classic features of aortic stenosis, fatigue, exertional lightheadedness, a late peaking systolic murmur at the right upper sternal border with carotid radiation and weak pulses. The best next step is an echocardiogram. It confirms the diagnosis and helps assess severity. Cardiac cath may be needed later for pre-op planning, but not initially. A stress test is risky if suspected severe aortic stenosis, actually. And while beta blocker might help symptoms, they're not the first step in diagnosis. Pretty simple, right? To sum it up, aortic stenosis is a progressive narrowing of the aortic valve that causes left ventricular pressure overload. The classic symptom triad is exertional dyspnea, angina, and syncope. On exam, look for a late peaking systolic murmur at the right upper sternal border that radiates to the carotid arteries. And remember, once symptoms appear, that's your cue. Severe symptomatic AS is a clear indication for valve replacement. That's it for today, guys. I hope you enjoyed the session and learned something valuable. Thank you so much for your time and attention. See you next time.